to our session today. Today's session is learning from positive deviant local health departments in maternal and child health. Our presenter is Dr. Tamar Klaiman. She's an assistant professor of health policy and public health at the University of Sciences in Philadelphia. She conducts public health systems and services research and teaches public health policy and management, social and behavior foundations, and disparities. She also advises students as kind of just a general faculty role at the University of Sciences. So much of her research focuses on using positive deviance methodology, which she'll explain today, in order to learn from high-performing state and local health departments. And really her focus of her work is to share best practices with similar organizations in order to improve population health outcomes. She's worked in the areas of emergency preparedness and response, clinical health registries, and maternal and child health. And she's been funded by the Robert Johnson Foundation, the California Healthcare Foundation, and the Centers for Disease Control and Prevention. So with that, let's go ahead and start.
Thanks, Rick. Hi, everyone. I'm Tamar. Some of you have heard a little bit about this before, so I'll try to not talk ad nauseum about things that you've already heard. I'm going to move this so that I don't end up wearing it. So I'm going to talk to you today about positive deviant local health departments in maternal and child health, as Rick so eloquently stated. Thank you to the Robert Johnson Foundation for funding for this project, and thank you to the National Coordinating Center that has been tremendously helpful throughout the whole course of the project, and I'm very happy to be here to present this work to all of you. So the objective of this project was to identify and learn from local health departments in communities where maternal and child health outcomes are better than expected compared to their peers. So we looked at within-state comparisons across 3 states, Washington, Florida, and New York. And our interest was not only identifying who was doing better, but also taking into account local context so that we could compare similar communities to each other. And context includes things like geography, population demographics, and finances across the public health system and the community at large. We used a positive deviance framework. Some of you may be familiar with. Those that are not, it's not as sexy as it sounds. But it's really identifying high performers. And positive deviance started, at least in public health, with the idea that there were already folks in the community who were doing behaviors that led to better outcomes. And learning from those behaviors could help teach others how to emulate them. The way that it's applied here is a little bit newer of an application in that we're looking at systems rather than individuals or individual communities. So our interest was really looking at the public health system and both local health departments and then some of the folks with whom they work. And what's important to note is, again, this idea of context, of understanding the circumstances that different systems or individuals within a system find themselves so that we can learn based on the context that exists. For example, you might look at New York City and see that there may be really good outcomes in certain areas, but you wouldn't be able to replicate those outcomes in a place like Lexington because the resources are very different, the populations are very different, and access to various services might be very different. So our interest is really in comparing like communities or like systems. And the idea behind positive deviance is to improve performance and quality among whatever outcome it is you might be looking at. So in this case, we looked at maternal and child health outcomes, but you could really apply it to any outcome that you have an interest in. This gives you a sense of what the positive deviance method looks like. So the first step is to identify the positive deviance, then do some in-depth analysis and understand why they might be positive deviance, and develop some theories about what's working and why. The next step is to test hypotheses that are developed in step 2 in a larger population, and then step 4 is disseminating the results of the first 3 steps. This project focused only on steps 1 and 2 for a few reasons. One, because of data accessibility, also because of time constraints and funding. But of course, should there be more funding, we would love to move on to steps 3 and 4. And Rachel Hogg and I have been talking about testing some of the theories that we've developed in steps 1 and 2 in the 3rd step. So in order to operationalize our idea about how to identify high-performing communities, taking into consideration local context, we use a realist evaluation framework. And so this framework considers the interaction between contexts and mechanisms that lead to specific outcomes. So, for example, you might have a large urban local health department, which would be the context. Those are things that the health department can't change. So it's situated in an urban environment, it has a high number of FTEs, large number of resources. Those health departments might form coalitions with partners, formal coalitions like memoranda of understanding and very structured relationships, which might lead to increased referrals for services because you've got these infrastructure to share the resources and relationships. As opposed to maybe a suburban local health department that's in a conservative community and utilizes, for example, community health workers who may not be paid staff, which might lead to more discussion of safe sex in schools. So you've got this interaction between the context over which the health department has very little control, plus the mechanism, which are specific activities that they can control. Who do you work with? Who are your partners? How do you establish those partnerships? What kind of stakeholders do you bring to the table that then lead to specific outcomes? And so our interest was in trying to characterize these kinds of relationships by doing in-depth analysis of positive deviance. So we used a mixed method approach. The first step was to identify positive deviance quantitatively, and then the second step was to do in-depth interviews with positive deviants, and I'll describe each of these steps in turn. So for the identification of positive deviance, we use the Public Health Activities and Services Tracking database. Some of you were here this morning when I described where it's from, but it's at the University of Washington. Betty Beckemeyer, who was my project mentor, is the PI on the FAST project. And we included all local health departments in Washington and Florida, and then in New York we included 48, which excluded New York City and 8 other health departments due to some lots of missing data. The data were from 2009 and 2010, which were the most recent data available. And the data are uniquely detailed and matched expenditure and outcome data. So it includes a whole variety of types of expenditures, some specific to maternal and child health and some more general, and then links it also to county health and county health outcomes. So we used multiple regression and this was a multi-step process. So first, I'm just going to tell you about the kinds of factors that we included, and then I'll tell you specifically what we did. Rather than having to read Z, X, and Y specifically, Z are just those variables over which health departments have minimal control, things like budget, which arguably they have relatively little control over, population size, geography, demographics, et cetera. X are the variables over which local health departments do have some control. What was interesting about this domain was that there are not a lot of data about the things that local health departments do have control over. So we included what we could based on the data that were available, and that included assuring that services were provided through alternative providers, having a clinician as a top executive, and then specific types of services that were provided, all of which local health departments have at least modicum of control over. And then our outcomes were maternal and child health specific outcomes, including teen birth rates, lower no prenatal care, infant mortality, and percent of low weight births. So we used regression analysis. We first looked at the factors that local health departments could not control, so those environmental factors. And then we added the variables over which local health departments had some control. We use likelihood ratio tests to determine whether the internal control variables, so those things that local health departments are able to have some say in, if they added any explanatory power to the model that we built. And what was really interesting is that they really did not offer much explanation for the outcomes that we were looking at. I'm going to show you a specific example in 1 minute. So just to give you a sense of the sample that we ended up with, we had 50 positive deviant local health departments across 3 states. We created an index to ensure consistency in positive deviance. So we looked at were they positive outliers either in multiple outcomes and or over multiple years, because we wanted to make sure that there was some semblance of consistency across the positive deviance that we identified, rather than including those that may have been an outlier without being a consistent outlier, that it was sort of a fluke that they had no teen births that year for whatever reason. So 90% of those that we identified had better than expected outcomes over 2 years, and 50% had 2 or more exceptional outcomes in a single study year. So we felt like we were getting a pretty good sense of those that were doing better than their peers. We realized that we probably, have more than maybe would be, 30% felt like a lot, but we wanted to be more inclusive because we wanted to learn as much as we could about those that appeared to be doing better. So this is a slide that I was referring to a few minutes ago when we looked at some of the variables that we expected to have a big impact on the outcomes that we were interested in. We would expect that financing would have a pretty large outcome, right? There's been a lot of data to show that public health financing has an impact on outcomes. But what was interesting was that in our analysis, we actually found that when comparing positive deviants and non-positive deviant local health departments, there were a few cases where funding did not seem to, was not the sole explanation for the outcomes of interest. So there were some cases where the positive deviants actually had lower levels of funding, or not funding, but expenditures, where they actually spent less but still had better outcomes. So what that told us was not definitively that funding doesn't matter, but more so that there might be other factors that make a difference in terms of community health outcomes in maternal and child health. And so that led us to step 2, where we did some in-depth analysis to try to understand what were those factors that might make a difference beyond funding. So we conducted interviews in each of the 3 states. We had very high response rates across each of the states. Granted, they're each a pretty low end, but still 70% response rate, even for 10 local health departments. I felt pretty good about that. And here are some of the characteristics of the local health department jurisdictions across all of the states. We interviewed people whose titles included Administrator of Environmental Health, Community and Family Health Managers, Public Health and Human Services Administrators, Public Health Nurse, Nursing Supervisors, Community Health Directors. The local health departments could identify for themselves who they wanted us to talk to. We gave them an executive summary of we contacted the health director, we gave them an executive summary of the project, and then they decided who would be on the call. In some cases, it was only one person. In some cases, there were 3 or 4 people on the call to give us as robust information as was possible. Our interview protocol was focused on 3 focus areas: assessment and policy development, research and evaluation, and regulatory oversight. And we contacted all 50 positive deviants, 39 of which participated in our interviews. So 78% across the states, which I felt pretty good about. So in terms of some of the results from the interviews, all local health departments depended strongly on partnerships, all the ones that we talked to who were positive deviants. The structure and the implementation of those partnerships did vary, though, across context. So for example, in rural communities, they might depend much more on informal networks and partnerships that led to better outcomes. For example, there were some health departments that would say, oh, well, when somebody comes in for a pregnancy test and it ends up being positive, I can call Sue down the road and I can send that client to her for prenatal care, for example, as opposed to larger, more urban local health departments that might have much more formal referral networks to services in the community. Also, many of the partnerships that seem to be effective, they share a lot of information across partners. So health department shares information with the hospital, who shares information with the schools and the like. And here are some quotes that are some examples of what folks said about partnerships. The other big finding that we discovered was that the positive deviants that we talked to had clearly defined goals that were based on data. So the data looked very different across different health departments. There were some that had very centralized systems of data collection, like in Florida. They have a very robust data collection system that all gets fed up to the state. Less centralized states have much more disparate data systems. Some of them, use Excel spreadsheets to collect data, population health data. However, we did find that the positive deviants that we talked to really wanted to focus on using data to identify their priorities. And in some cases, it meant discontinuing services that they really cared about, but that weren't addressing the biggest needs in the community. And what we saw over and over again is that local health departments are really making a shift, in many cases, from direct health services to population health services. particularly in areas where there are other providers, as opposed to areas where there are few providers. And I'll talk a little bit more about that in a minute. We also discovered some interesting challenges that kind of cut across the board. Now, the data that we used was from 2009 and 2010. So the impact of the 2008 financial crisis hadn't really been felt yet until toward the end of 2010, 2011. And the local health departments felt it very strongly at that time. So when we spoke to them, a lot of them said, you know, in the past 5 years, our funding has been slashed dramatically. Particularly actually in urban areas, because rural health departments have such small budgets to begin with that very little was cut from them. But the urban health departments, the larger ones, they've really felt a big shock from reduced funding. So that was really a challenge, and they had to reprioritize what they wanted to focus on because of those funding cuts. Another issue that came up again and again was staff turnover and staff training. So first you have the issue of staff turnover. You train somebody, they're there for a little while, then there's no funding to give them a raise or better benefits, so they leave the health department. In addition, a lot of local health department staff are trained to do one-on-one, especially maternal and child health. They're trained to do one-on-one interventions. Public health nurses, they can go to your house, they weigh the baby, they do any wound care after you give birth, they maybe they check the baby's weight, et cetera. They're really used to that one-on-one interaction. Because of implementation of ACA and Medicaid managed care in some communities, the public health nurses who used to do that work cannot do that work anymore because local health departments can no longer contract with Medicaid managed care. So they've really had to shift to a much more public health education role where they might do a home visit, but they're not doing those direct clinical services. They're talking about safe sleeping and baby-proofing a house, as opposed to treating the baby and mom in the new family. And that's been very, very challenging for a lot of staff at local health departments who haven't been trained to do that. There are some staff who've worked for 30 years at a local health department and they say, I don't want to learn how to do that. I want to be doing what I've been doing for the past 30 years. So that's been a big challenge. The other issue that I brought up before was variations in data collection. And so it's sometimes very difficult to compare across health departments or across communities because the variation in data collection is so great. I think compared to 10 years ago, there's a vast improvement, due in large part to the work that the PHSSR community has done. But at the granular level, at the local health department level, this still continues to be a challenge for a lot of folks. And they might get data in aggregate from the state, but many of them have a hard time getting sort of lower level data by population groups. So, excuse me, so some of the implications for policy and practice include focusing on establishing partnerships. So if you're a local health department and you're trying to figure out how do you improve your population health outcomes with the limited finances that you have, based on the experience of these positive deviants, we found that partnerships really can make a huge difference. And partnerships doesn't necessarily mean contracting out services. It might mean offering technical expertise to folks who are already offering services. It might also be doing data analysis. There are health departments that have staff that are trained to do data analysis and can do that for their partners, and vice versa. So there are some health departments that work with universities to have them do some data analysis for them. Also referral and administrative services, and we saw that in many cases this is really where local health departments are moving into this referral and administrative role, where they help people, for example, get on Medicaid when they become pregnant, and then they send them to providers in the community. Also data-driven activities, investing in robust data systems. We talked to one local health department that just implemented an EHR system, and it's a pilot in Florida, and they've got this really robust system that they're very excited about. It sounded fantastic, and so they were lucky that they had the resources to do that. There are other communities that even having an access database might be a more robust data system than they have. So it depends on the context. Also focusing on community priorities. What does the community care about? What do the data show in terms of what's going on in the community, and then sharing those data with the community to get their feedback about how to address those issues. And then population-based services. A lot of local health department staff said, we need to do things that give us the biggest bang for our buck. And in many cases, that means population-based services as opposed to direct individual services. So before I talk about translation and dissemination, I did want to sort of anecdotally note that we did also speak to some negative deviants. We didn't say that they were negative deviants when we spoke to them, obviously. And I hate to use that phrase because it's not that they aren't doing good work, it's just that their outcomes are not as good as some of their peers. And what we found was that a lot of them understand the importance of many of the things I just talked about in terms of partnerships and using data and evidence-based public health, but a lot of them are not at the point where they can do it yet. So some of them said, well, we really want to partner with some community agencies, but we're sort of trying to figure out how to make that happen. We're trying to build a coalition, but we've had a lot of staff turnover and we don't really know how to do that yet. So at least anecdotally, it looks like the results that we found are reflective of something that's actually going on and the difference between the high-performing and low-performing communities. So in terms of translating and disseminating the results of this work, we developed 3 infographics by state, and those are actually on the table over there if you're interested. Kara Richardson was a tremendous help doing that, changing all the words I wrote into pictures, which I'm not good at doing at all. And we shared those infographics both with our the folks that we interviewed, as well as state health department staff. And then we also presented the work at the Florida and the Washington State Public Health Association meeting. The New York Public Health Association meeting didn't occur by the time we had the results, it had already happened. But we have talked with the state health department, and they have found our results very helpful in terms of figuring out where to go moving forward. We also have 3 manuscripts. One was published in Frontiers and PHSSR, and we have 2 more under review at Maternal and Child Health Journal and the Journal of Public Health Management and Practice. And then we also developed a research brief that should be posted on the Academy Health website if it's not already, focused on the Washington analysis that we conducted. And I'm here. And we did a webinar. So in terms of next steps from this research, the first thing is, I think this idea of validating the positive deviance method and trying to get to step 3, where we can test some of our theories in a larger sample. So we've been talking about using some partner data that Rachel has access to, and including some of our positive deviants in doing some analysis to try to see if our theories are actually legitimate, aside from the fact that Tamar Klaiman says they are. Also, applying positive deviance to other areas of inquiry. So I'm working on a project now looking at clinical service delivery among local health departments, and we're trying to identify positive deviance, particularly among high-need, low-resource communities in terms of clinical service delivery. And then it also can be applied to other areas, other areas of inquiry, but also we'd like to learn more from positive deviant local health departments in other focus areas, and also get the work that we've done translated back to those who might need the most help. And so we've been thinking about maybe looking at some HRSA funding or some other funding mechanisms to develop some learning collaboratives so that local health departments can share their lessons learned with peer communities so that they can try to cross-pollinate and learn about what's working. So in conclusion, I want to thank again the Robert Wood Johnson Foundation. I also had 2 phenomenal research assistants, one from University of the Sciences, Anjali Chinani, and Athena Pantazis from University of Washington. The interviewees were fantastic. It was interesting talking to them because they, you say, oh, well, we see that you're doing a really good job and your outcomes are really good and we want to find out more. And they say, what? No, I think your data are wrong. I can't tell you how many people had their data managers or epidemiologists call me and say, well, where'd you get your data? I don't think, and I said, it's actually reported to the state from your health department. So this is data that you reported. And they're like, we didn't think we were doing that well. Or they'll tell you all the things that they don't think they're doing well. Well, we really could do better at this and this. And I'm like, oh, that's really interesting. But could you tell me a little bit more about the things that are working for you? And they, they had a hard time sometimes doing that. And we also had a fantastic advisory council with some great researchers and also practice folks who helped us translate our findings into something that would be useful for the consumers, hopefully, of the work, particularly the practitioners. And if you have any questions or discussion. Yeah.
So I'm maternal and child health as well.
Oh, great.
I worked for Frankfurt for a number of years in our state capital. So I'm wondering, when you looked at the maternal child health outcomes like infant mortality, low birth weight, did you look at race, poverty, and those factors and adjust your outcomes based on population makeup?
So we included population makeup in our analyses, but we didn't cut the outcomes by those factors. However, when we did our interviews, a lot of those issues came up when we talked about high need populations and vulnerable populations, and so we let the health departments, we asked them for that kind of information, but in terms of the quantitative data, we didn't. County level data, some of these counties are so small that having done that would have not given us great results. It just would have been too small of groups. But we definitely took that into account and thought about vulnerable populations, and it varied. We talked to some counties where they had high rates of Amish and Mennonite populations, and then others who had high rates of undocumented worker populations. So it was really interesting, different regions of the country, what some of the issues were among those subpopulations. Yeah.
Right. So you looked at 3 states, right? Florida, Washington,
Yeah.
Who are probably not. They're probably higher performing public health systems.
Mm-hmm.
I mean, the fact that they can be participating fast suggests they have really good data collection.
Absolutely.
So what are kind of the next steps you might take to see if what you're finding here applies kind of in a larger context?
Yeah, that's a great question. So, so part of the reason we chose those 3 states is because they had such good data. Most of the, we did a lot of within state analysis, so that because of that reason, because you can't, it's hard to compare those states with really robust systems with others. Pennsylvania has, I think, 5 local health departments in the state. So obviously the comparison is not the same, it's not going to be the same. So ideally, I know that Betty is working on getting additional data in the FAST database from other states. And if we can do some of the, to me, this is very much an iterative process. So if we can test some of the theories that we developed in the states that we've done this, and then go into other states and see if it applies there as well, I think that, I think that could be really useful. But it's a huge limitation. The lack of data in other states, these kinds of data is really challenging, and it's a big limitation of the study. Helen, did you have a question?
Yeah, the question has to do more with negative deviance and people who aren't doing well.
Mm-hmm.
And in performance improvement, you learn a lot from accidents or near misses or kind of things that went badly.
Yeah.
And so, just sort of interested in your perspective on what we might take away. You only had a couple of the negative deviants that you talked about.
Right.
What you might take away from that.
Well, I think that's a really good point, and a lot of the work that I did prior to this was in emergency preparedness, which focuses a lot on what didn't work very well. And I really feel like we spend a lot of time focusing almost too much on what doesn't work, and so to me, using the positive deviance approach is a nice way to see what is working and then try to apply it to systems that aren't working as well. The other thing is the negative. We reached out to a lot of negative deviants to try to interview as many as we could, and we got responses from like 3. And so, which, may not be all that surprising, because if they're not doing, we can hypothesize all day about the reasons why. So your point is well taken, that we can learn from what's not working that well, but I try to think of it on the flip side of how do we learn what is working well and then apply it to situations where things aren't going so well.
Yeah, negative deviants maybe can't even articulate their problems.
Yeah, I think that's that's a really good point, because the positive deviants definitely can. That was clear. Like, they definitely say, here are all the things we're not doing right, or here are all the things we wish we were doing better. And the negative deviants, that might be true, that they can't even really articulate what's not working. All right, did I talk too fast? I did, didn't I? We still have 30 minutes.
I have another question if you want to answer.
Sure. I don't know if I want to answer it, but you can ask it.
So obviously in public health and healthcare, we've kind of seen this really significant shift with the advent of the Affordable Care Act, right? We've got folks, we have Medicaid expansion, we have expanded private insurance. So I think with that, do you think the role of the health department providing services related to these MCH outcomes might have changed? And if so, how might that kind of affect what you're looking at?
Yeah, it definitely has. I mean, there's no question. So even in non-expansion states that, but have made changes to Medicaid, like the implementation of Medicaid managed care, which didn't exist before in Florida, for example, that's had a huge impact on the kinds of services local health departments can deliver. And also, it's had an impact on access because a lot of, at least this is the experience in Florida, that a lot of folks who used to go to the health department for primary care services are being pushed to FQHCs. FQHCs require a copay, even if it doesn't sort of matter what your income is. If you don't pay that copay, you can't make another appointment. So even if you have a $10 copay, if you can't get together $10, you can't be seen. Whereas at the local health department, you could be seen without paying anything. It has a huge impact on the kinds of services that are being provided. The study that I'm working on now, looking at clinical service delivery, we're hoping to get at some of that. What is the impact of the ACA implementation? And in the expansion states versus non-expansion states, particularly in communities that depend on clinical services from the local health department, how are those policy changes impacting health department ability to deliver those services? And where is it working and where isn't it, and why not? Absolutely, I mean, I think there's no question that it's having an impact. The other thing too is that, there are situations where the health department might not be the best provider of services. There are a lot of, especially in urban communities where you've got a lot of providers. I think about Phladelphia, where we've got like 6 major healthcare systems in the city, all of whom have clinics, and there are multiple FQHCs. I don't know that people need to go to the health department for primary care services. It may not make sense for them to be offering those services. But there are also rural communities where there isn't a doctor for 200 miles. In those cases, maybe the local health department, it does make sense for them to offer primary care services. So, that was a really long-winded way to say, yes, I think that the federal level policy changes and even state level are having an impact on the kinds of services that are being provided.
But in your outcome data, we start pre-ACA, right?
That's right. Yeah, but our interviews were post, so some of what we've written in the manuscript that's under review at JPHMP talks about those issues. And this is the challenge of having sort of older data. So on one hand, it's a challenge because we don't know what it looks like now, and my hope is that we can actually do an updated analysis with more recent data. That's kind of the next step for this, to see if these things still hold true, given the policy changes. But the nice thing about it was that we could talk to people, and they told us about what those changes meant for them. So at least we got the qualitative piece that allows us to start thinking about, okay, well, what kinds of questions can we ask now with more recent data about the impact of these policies on outcomes.
So, somewhat related question. This is studying these issues in the MTA service line is interesting for a number of reasons. But one reason is just from a political economy perspective. This is one of the areas where the federal government has historically and continues to play a large role in financing these services. We have the MTA block grant, which is one of the longest standing federal funding mechanisms for public health services. And presumably, that's the ultimate source. That plus the state match is required for block grant is the ultimate source for financing a lot of the services that you're studying here. So my question is, but that is a block grant mechanism. So, and I know we had discussions earlier about what the statement you made earlier about this funding. Is funding within the control of the health department or not? And certainly at the local level, you can argue that it's perhaps less discretion over funding, but for MCH at the state level, there's a lot of state discretion in how much money they get, because that's a federal formula, but how they use it.
Yeah.
That's the beauty and
the blessing and the curse.
Of
Yeah.
the block grant mechanism. So, okay, I guess have you interviewed any folks at the state level that could give you any insight about the decision making and policies that are playing out at the state level that may be driving some of the positive patterns?
That's a good question. So I have had conversations with the people at the state level, but not formally. They've been, sort of at a meeting kinds of conversations. So when you do the within state comparison, it's less of an issue as the across state because they're all sort of getting the same, it's the same formula within the state. Like, so within Florida, the same formula is being applied for funding for all, at least from the state money to the local health departments. Doesn't mean they're all getting the same amount of money, just that the formula is standardized. So yes and no. I mean, what's interesting, which is not a direct answer to your question, but I did speak to a local health department the other day, and they are terrified that federal money is going to go away. I mean, they said to me, they are highly dependent on local tax dollars, which are going away. Most of at least the Medicaid covered services are actually covered by, the gap is covered by local taxes, which are going away quickly in many states. And they're really afraid that the Title X money is going to disappear. And that, which was kind of a shock. I mean, that's sort of always been there. But local health departments are they're bracing themselves for that money going away. So, I mean, I think your question is a good one. We didn't do formal interviews, and it might impact, it could, I guess the answer is I don't really know. I don't know how much it impacts the positive deviance. I like to think that with the within state comparisons, because the formula is pretty similar across health departments, that you're still able to compare somewhat apples to apples. But there probably are some communities that are getting, they apply for a grant at the state level, and they're getting that, and their peers aren't. So we did find some creative mechanisms for funding that some local health departments were using, like applying for their own grants from the CDC or other foundations. So that was definitely, finding creative ways to get money was pretty consistent. There was another local health department that went back and back billed for services that they hadn't billed for from Medicaid and private insurers. And they got it was like a windfall because they hadn't been billing for all these services. They did chart reviews, and they went back and billed for a whole bunch of services that they hadn't billed for before. So that to me is the sort of mechanism for the positive outcome. The mechanism is finding a creative way to get more money. Preferably legally, but.
I'll ask a partnership question. Did the health departments that you talked to have close working relationships with the local Medicaid office and the local DCBS office? Because some places that's not happening anymore.
It depended. So in some cases they were in the same building, which helped. In some cases they no longer have relationships with Medicaid because they can't contract with them anymore. So they've been told, like in Florida, there are very few, if any, health departments that are still providing services that are Medicaid reimbursable because of Medicaid managed care, and they've been told that that's not their responsibility anymore. So it really varied. New York and Washington are more decentralized states, so that there was more variation in terms of those relationships.
How about DCBS?
What's DCBS?
DCBS is the social services.
Yeah, so lots of social, yes. So those partnerships were very robust, very robust. In some cases it went across the gamut, WIC, Healthy Start, and early intervention, and children with special health care needs. They very, very close relationships. In a lot of cases, local health department is in the same building as the social service agencies. And so they have, a lot of referrals, even lactation consultants who are health department staff who go into the hospitals, they may refer for early intervention if a baby's not thriving, so absolutely. But what those relationships looked like varied. Some cases they were very formal partnerships, and in other cases it was Sue works down the hall for me, so I call her when I have a problem. Mm-hmm.
What was your most surprising finding?
That's a good question. I haven't thought of that before. You put me on the spot here. I guess this maybe shouldn't be surprising, but I was really in awe of the work that these folks do. With very little pay, very little thanks, and very little community recognition of what they do. And they come into work every day, and most of these folks are doing the job of 8 or 9 people, and barely getting paid as one person, and they love doing it. You know, the other thing that I thought was kind of surprising, and this only happened in one case, but I had one interviewee who was clearly a political appointee to the health department. I think he was like the health director. Clearly did not know very much about public health, and then also he included some of the MCH staff on the call, and he was literally reading from like I would ask a question, he would read off of the website, and then the staff would say, well, actually, that's not how it's done. And so that was very interesting that here, like in this, you know, somewhat public forum, the health director had really clearly had no idea what was going on, and the staff clearly did know what was going on. And it only happened in one case. Most of the other times, either the person that we reached out to really did know what they were talking about, or they farmed it out to the right person, and it had very good work. And you could tell their internal working relationships were good. But that was one very interesting situation where the answers were very political, very non-committal, you know, saying a lot of words without actually saying anything that meant anything. So that was kind of a surprise to me. Rick?
I'll ask a softball question. So earlier in your presentation, you alluded to the fact that this was a really novel approach in the use of positive deviance, given that you look at systems on people.
Right.
So what would you do differently, given that you really didn't have anything to kind of guide you? Like, what would you have done differently if you did it again?
That's a good question. So one thing that I think I would have done differently is I would have, we went right to local health departments to ask for their participation, and in some cases that was fine. Like in New York and Washington, the state didn't care about that. Florida, they did not like that. The state was not pleased that we went directly to health departments, and they gave approval once we reached out to them, because we didn't know that we should have gone through the state. Lesson learned on that one. And so we went through them. You know, we did go through them for approval, and they did approve. But I'm working on another project, and they've declined to participate. So I've been working really hard to make nice and to share all of our results with the state and sort of repair that relationship. Most of the other state folks were very supportive and were very excited to hear what we learned. And their lack of participation in the next study might have nothing to do with me. Like, it could be taking it personally. It might have to do with the fact they have a million other things to do. But I'm trying to, you know, mend that relationship. So that I would do differently. I think, I learned a lot, but I feel like the processes we used were, given the limitations that existed, I feel pretty like we did a pretty solid job. I probably would have more note takers and more coders for the qualitative data. I have one student who's working with me on the coding and the analysis, and it's a lot of data. 39 interviews to code those interviews. And to double code them and then figure out, make sure that the coding was consistent. That was onerous.
So each student, you had two folks code each interview then?
Yeah, so myself and a student, and then we went over the codes, and anytime there was a disagreement, we talked about, yeah. And for this kind of study, we did, you could code things, I'd have one sentence and have like 6 different codes for it, which is, yeah, it's a lot.
You read it 6 different times.
Well, exactly, right. Then you like print out, I want codes only for partnerships, and you're like, I've literally read this 8 times. Like, it's partnerships, it's funding, it's Medicaid, whatever. So, did you have another question?
Yeah, I was wondering number one, what software you used for that, and number 2, did you have a transcriptionist transcribe your discussion, or how did you do that?
So we didn't tape the interviews. We took notes. Myself and there was always a second person on the call, almost always my research assistant, and we both took notes, very detailed notes, and then we collated the notes to make sure that nothing was missed. And we used Atlas TI for coding. Yeah, and the challenge for us was that Atlas TI, I am a Mac user, and so in the beginning they didn't have a Mac program for Atlas TI, so I had a laptop that then got destroyed from a bottle of club soda, which was like its own drama. And then they were still building up the Mac platform, and so there was a little bit of a issue with the coding wasn't the problem, but the analysis, like some of the pieces weren't done yet on Atlas TI for Mac, so that was a challenge I did not expect. But I love the software now. It's very useful.
Did you
choose to not audio record the interviews because of
We did.
audience?
Yeah, so, you know, a lot of the, we really felt strongly about anonymity, and, you know, the other, some of it was just practical sort of IRB issues, that it would have taken longer to get approval, and it already took a long time, and even though it was exempt and whatever. I was just talking about that earlier, about another project. So, and also, I don't feel like we missed anything from not taping them, because we had enough people taking notes. And then the quotes that we used, you know, we went back to people and said, we would like to quote you about this. Are you comfortable with that? Are we are we misrepresenting what you meant? And everybody's been, it's not been an issue.
So, a question, your study obviously focused very specifically on local health departments and the roles they're playing in the service delivery. Do you have any thoughts about the extent to which some of the positive deviants you may be seeing are due to contributions being made by other sectors?
Absolutely.
Outcomes, whether it's education or
Yes.
clinical service providers or others, given what we know about the drivers of some of your outcomes and what you got about how that might be.
Yeah, so absolutely. I think there's no question about it. I mean, you know, health outcomes are not the result only of local health department work. So this was very discrete. To me, this is a first step of, 25 more steps. The next step is to look at who are the health departments that were positive deviants. Who are they working with? What do those relationships look like? And do they look similar across different communities? I have no question that in some places, schools, the relationship with schools was tremendously important. In other places, it was the relationship with social service agencies. In other places, it was a relationship with hospitals. And that's only based on talking to the folks at the local health department. You could talk to the hospital, and they might not even mention the local health department. They might mention 25 other community-based organizations that we didn't capture. So no question about it, there's other factors that are at play. To me, this is one piece of a research agenda, and it was a piece that was discrete and we were able to carve out. But I absolutely think that I have many more questions than I have answers at the end of this project, which is, I guess, a sign of good research, right?
So what
In my
would
mind.
your priorities be for the next steps?
So I think the next steps are to test some of the theories that we have using tools like the partner tool that Rachel and I have been talking about, to try to better understand the relationships that matter and what start to characterize them, and then replicate them. So
The relationships between health departments and other organizations.
Well, or community partnerships generally. I think we would probably start with the health department just because that's the data that we have, but and those are the connections that we already have. So it's it's easier for me to call somebody who I've interviewed and say, listen, we're working on the next step. Would you be willing to work with us to communicate with your partners? But it's possible that those partners, they have other relationships in the community that have very little to do with the local health department. But I think that the next step is to try to better understand what those relationships are. I think there's no question that partnerships matter. I think that we have a hard time quantifying what that means. What kind of partnerships, what are the strengths of those partnerships? And I think it varies by context. In rural communities, it really is those informal partnerships that make a huge difference. In urban communities, it's much more of those formal, legal partnerships, the contracts, the formal coalitions that I think make more of a difference. So starting to try to get at, what's going on in those different communities and contexts regarding partnerships. All right. Thank you, everybody.